Good evening and welcome to tonight's webinar. My name is Adam and I'll be your moderator. Tonight we're joined by Dr. Lori Trost and she'll be reviewing posterior composites. If you have any questions, please add them into the Q&A section and we'll reply via email within 2 business days. Henry Schein is not offering CE credit for viewing or attending this presentation, live or on demand. And tonight's webinar is sponsored by Dentsply Sirona. Dr. Trost, welcome.
Hi there, and thank you, Adam, for that nice introduction. I'm Dr. Lori Trost, and I'm happy that you're joining Crash Course Build a Rock Solid Posterior Composite. Just a little view and insight into my practice. I want to disclose that I am a clinical evaluator for Dental Advisor. I enjoy evaluating materials and products within my practice, and they give me a wonderful opportunity to do so. I also want to tell you that I have no conflict of interest or financial support from any of the mentioned materials or products in this program. With that said, I do use all the materials and products that you will see. So these are used in my practice daily, weekly, monthly, and yearly. And a final thanks to Henry Schein and Dentsply Sirona for sponsoring this program. I really value their commitment to education. That's so important. And as a comprehensive restorative dentist in the greater St. Louis area, I can tell you it means a lot to dive into education and to have the methods and the means to be able to share and to learn and to grow and practice and share with all of you. This is a very exciting time because, we look at composites and most of us do 20 of them a month. And that is a considerable amount of dentistry, a considerable amount of time and productive time that we spend in our offices doing these. And more importantly, they're frustrating sometimes. They're not the success sometimes is challenging. They can become chaotic. Tissues are not always managed. Patients can't always stay open. These are tedious. They're delicate. They need to be beautiful. They need to be lasting and durable. But regardless of all of that, about 2 out of every 3 patients you have walk in your practice, you will probably most likely do a posterior composite. A lot of times it starts as a class 1 and then moves into a class 2. So we really have to know how to do these well because they consume a lot of our time, a lot of our productivity within our practices. And, like Einstein said best, insanity, doing the same thing over and over again, expecting different results. And it's critical that we learn to master certain procedures and gain an understanding of what we can really benefit and leverage within our practice to create a successful outcome. So I'm excited to be able to show you some of these ideas. So what does make a posterior composite difficult? It's challenging sometimes. They're frustrating. They can throw our schedules off. Sometimes things happen and we just don't predict or necessarily understand. So, honestly, we inherit a lot of older amalgam designs that we see initially within our practices. And there's different, varieties that come within a quadrant. You can see here in this upper left picture. Then we have, once we remove many of those older amalgams, we see a crazy undulated occlusal floor like you can see on the top right. And we have to know how to manage that material that we're going to place in there. What's our choice? Why would we choose certain materials versus others? More importantly, is it going to be successful long-term? And then you can see on the bottom left, we have a over-contoured existing restoration that we need to manage probably to make a more fitting and better reestablished contact once that premolar is restored. And finally, you can look at another key element is isolation. Isolation is key to creating really exceptional adhesive dentistry, but really we have to know how to understand to seal the box. And we have to have the right kind of materials, the right kind of equipment and instrumentation in order to do that. So this course is really going to cover a lot of that over-the-shoulder, everyday bread and butter dentistry that we all do. Some of the topics I'm going to really focus on are how do you use a universal bond agent? How does it really work? And what methodologies? Where does that play out? And then what is a bulk fill? There's a lot of confusion today. These are questions I routinely get asked. And what is a bulk fill? We'll talk about that. Is bulk fill a one and done? Is it incremental? Does bulk fill mean that I can do a faster restoration? What are the benefits of a bulk fill? And a really critical question is, how can post-operative sensitivity be reduced? Many of us have been doing composites long enough. We understand how we've moved through improvements in materials and adhesion and techniques. But we also have to come to understand it's very much technique sensitive. And if we can use certain benefits of different materials, we can really reduce that. And then, of course, always the elephant in the room about polymerization, shrinkage, and stress. How do we reduce that? How do we have a great outcome for that patient that doesn't create a white line or a stained occlusal table at some point in time, that we know we've done a right procedure incrementally, correctly, and solidly? And then finally, how can you establish tight contacts? Seems simple, doesn't it? But it's not. And I think if you choose, again, the right materials, again, and the right frameworks, you can make that happen. Let's start off with the restorative interface. And it's critical to understand we have two different materials in which we're using within the body here. We've got enamel, which is very inorganic. It's predominantly hydroxyapatite, rich in calcium. And then you have dentin, which is more organic. It's hydroxyapatite driven. It has a lot of collagen. It has this nature where it has more moisture in it, and it's made out of tubules. We know we can absolutely bond, and the gold standard is bonding adhesively to enamel. And that's pretty relatively simple now and straightforward. But dentin is a different beast. And we're sitting there trying to take a material such as an adhesive bonding agent and placing it on both dentin and enamel. And we need to understand those dynamics to really benefit from what can happen successfully long-term. So with that adhesive layer, we're taking those two substructures and we're going to place that adhesive layer and then marry on top of that a restorative material. It's critical to understand that tubules, dentin tubules, are kind of like those pool noodles. I joke a little bit about this in programs where they're like the pool noodles that are standing up in your swimming pool, and you have to coat them, but they kind of wave around, and there's all these little fibers that we need to permeate and saturate with that adhesive bonding agent. And it's super important to understand we have to saturate that, respect the dentin, and keep it moist. Then the question becomes, how moist is moist? So what we know is in that restorative interface, dentin has different layers. And as you are more towards the occlusal surface, there's fewer tubules. As you move down in through the dentin and go deeper towards the pulp, you have more tubules. And what does this mean? The dynamics change within that structure. So we've got a more difficult area to really saturate that. And we've got to make sure that when we're applying our adhesive, it's critical to get in there and really scrub the adhesive bonding agent into the entire dental surfaces, along with the occlusal areas which are filled with enamel. So what we know is deeper dentin has more tubules, like I talked about. With that anatomy, the tubular dimension starts to increase. So now we have less minerals and we have more collagen. So there's less permeability availability to happen. So it's really important to make sure one step to help reduce your postoperative sensitivity, if you're having it, is to make sure you absolutely scrub that bonding agent with a clean microbrush, a clean surfaced, fresh drop of bonding agent into that area, and you saturate that, and you don't violate or shortcut any of that time or that application. If not, what will happen is you'll see dry dentin, and you're not going to be able to cover that. If we really dried the dentin and parched it, it's not going to be as acceptable. And therefore, we're going to have different types of interfaces that will fail over time. We've got to keep that pool noodle surface, that moist dentin, really vibrant and saturated so it can permeate. So literally it reduces postoperative sensitivity, creates a more durable faced bonding structure. So universal bonding agents today, there's a wide variety of them in the market. These all work well. It's really how you use them. And you have to understand each of these have different chemistries. They all rely on either an acetone or an ethanol base within their chemistries. They need to be capped tightly, make sure they're stored correctly. You need to make sure you shake the bottle or have your assistants shake the bottle. Some need to be refrigerated. Some are easier to thin. Some are more yellow. Some are more odoriferous. So you've got to understand its preference. But what I do believe is I think you need to stay in a vertical column when you select a universal bonding agent. You use it because you're going to use the composites and they marry well within that application. Each of these universal bonding agents right now, they're all 8th generation essentially. They offer three different types of etching methodologies. You have total, selective, or self-etch. And this is really beneficial because within a quadrant, say, of dentistry you're going to do within a patient, restorative dentistry, you're going to sit there and perhaps maybe have a presentation where you're going to take a total etch approach where you're going to really just etch the enamel. Predominantly, enamel is present. So therefore, if you total etch that for 15 seconds and then you rinse that, now you can apply your bonding agent. If you're going to do a selective etch, you can sit there and simply, this is a presentation where anatomy has dentin as well as enamel equally, and you can see how we can etch carefully around the enamel surface, rinse that thoroughly for 5 to 10 seconds, then lightly air thin that, and then apply the universal bonding agent. Again, most of these are a 20-second application on the bonding agents. And of course, if you have just predominantly a dentin presentation, you're going to select the self-etch methodology. We're going to take the universal bonding agent, and it's only going to be by itself. And you're going to apply it to that surface. You're going to scrub it, saturate it, and then you're going to air thin it. And of course, all these are light cured, and then you move on forward with placing your restorative materials. So when you're applying a universal bonding agent, super important to understand, first of all, you've got to agitate that. You've got to saturate the surface. You need to scrub with that microbrush onto the dentin, onto that enamel surface. Very, very important. Don't shortcut that. If the manufacturer recommends 20 seconds, it needs to be 20 seconds, and that's per tooth. Commonly, I'm asked, do you switch up microbrushes when you're? Yes, I use a fresh microbrush for each restoration. I just believe in that. I think it's a better approach. I get a better result from that. So, if we're doing a quadrant dentist, we'll have maybe 3, sometimes 4 microbrushes readily available to use to achieve that methodology. More importantly, I also use a fresh drop of bonding agent per restoration. So that's a really important thing. And my assistants literally will drop that fresh drop right onto that microbrush, and we will go ahead and saturate their restoration. Many of these bonding agents need multiple coats. So read the directions. Don't shortcut again. If they say 2 coats, if they say multiple coats, make sure you're really following what they recommend. Very important to do. Also, again, like I talked about the duration, most of these are 20 seconds of saturation or scrubbing, agitation. Some might go down to 10 seconds. Some have different light curing values as well. So understand how long it needs to be applied and how long it needs to be cured. Also understand that the evaporation of the solvent is going to be happening. It's a real thing. It's chemistry. As I mentioned earlier, you have acetone or you have ethanol, and these are all driven to literally help drive the adhesive agent into the tooth structure, and then that evaporation process happens. They're kind of like the messenger for the bonding agent. What you need to know is that cap or that screw or that lid on top of that bonding agent's got to be solid and tight, because you don't want any of this product evaporating chair side, table side in your operatories, or even perhaps even in your refrigerator. So that being said, make sure that the caps are clean. They can screw on tightly, be placed tightly, snapped on tightly, because this is something that will evaporate. Make sure your assistants understand that as well. And of course, curing time. Like I mentioned earlier, some of these are 20 seconds, others are a 10-second cure. And finally, again, read the fine print. Many of these are requiring refrigeration. So you've got to understand, you've got to bring that out perhaps in the morning, use it throughout the day, and in the evening, it goes back into your refrigerator. I'm in the Midwest, and we have humidity. We deal with temperature changes, variations, you name it all. And of course, we do refrigerate when it's necessary. Again, as I mentioned, scrubbing that universal bonding agent is so important. Put a generous amount onto all of those surfaces. Scrub the dentin, scrub the enamel. All of the preparation surfaces need to be scrubbed. If you're using a microbrush that tends to lose its toughness, switch brands. You've got to have a brush that can withstand that agitation and really deliver that product to those surfaces. Very important. The next step to really help reduce post-operative sensitivity is important. Understand, again, these chemistries. And what's going to be vital here to get is that we have to take this bonding agent and deliver to that tooth surface. Then we've got to rely on thinning of air. So you're going to be streaming a little bit of air. What's going to happen within this chemistry is, as you have the bis GMA and the monomers and the initiators and a solvent within that whole chemistry, the solvent is going to be the messenger into the two surface, and then it's going to literally, as you blow, it's going to be released and moved away and scattered out from the surface. So therefore, then the bonding agent can literally soak in and do what it needs to do. Now, if you just blow gently and kind of scatter the bonding agent across the two surface, you really create a layer, that adhesive layer that's very uneven. Sometimes it pools. Sometimes you can see the little ripples. It can scatter perhaps even into the corners of preparation, or areas or boxes that you don't really care to have it there. So you don't want to do a gentle blowing, just create a scattering. What you want to do is you want to blow very evenly. You want to blow longer. You want to make sure you're doing at least a 5 to 7 second air thinning to make sure that you literally are scattering out and chasing away the solvent as well as the water. And this is going to create the homogeneous adhesive layer that's really required. And more importantly, will help create a bonding surface interface that now will help reduce post-operative sensitivity. It will also make sure that down the road, perhaps there's not a question of maybe a thicker area that you didn't know was at decay, perhaps when you radiograph your restorations down the road. So here's the technique on air thinning. What I think you need to do is make sure you clear the airline. What I like to do is I use disposable air water tips on all of my patients. I believe in that. I think that obviously with infection control, I think that's critical. But what you want to do is you want to take a cotton roll and place that and have your assistant place it adjacent to the preps that you're going to be restoring. You're going to have them, and perhaps you might want to have your assistants do that. I do not. I clear the airline myself. I do all my air thinning of all my adhesives. So I'm going to go ahead and clear my airline into that cotton roll. And now I'm going to go about half an inch above the prep of the height and height of the prep rather. And then for 3 to 5 seconds, I'm going to literally just kind of zigzag across that preparation. And then I'm going to move closer into that so I can literally move and push out and force away all of that solvent and that water, so that I have a very homogeneous layer. And you can see it looks actually kind of shiny. And you know that you've really pushed all of that out and away and literally have got a very even layer. No rippling, no pooling, no waving. You do not want to simply just blow hard air quickly, 1 or 2 seconds over top of the preparation, because really it's not creating thinning. It's just displacing the bonding agent. And what can happen with that excessive film thickness, as I alluded to earlier, is that literally with a higher viscosity, especially bonding agent, you might really confuse that with being caries. You might have literally pooling that creates, again, an area that is just not as cohesive as it needs to be. And it could create literally, again, a void or a post-operative sensitive area. So again, make sure that you take the time, properly air thin the bonding agent, because you're going to have a much better result. So with that, you now move into composites. What are we going to apply into that now light cured, nicely homogenized layer of adhesive material? We've got 2 different methodologies now we're using in applications. For composites, we have traditional composites where we incrementally have placed 2 millimeters, 2 millimeters, and 2 millimeters all the way up to preparation to restore that tooth. More of the new thinking now is bulk fill materials. And bulk fill have the ability to be placed, and there's a couple different categories, and we'll talk about that in a bit. But these offer advantages because literally incremental filling offers times where you can have not only contamination, but an interruption in that perhaps seam of where you're marrying those materials together. It's time consuming. You also have to think about the stressors that are placed on those surfaces. So incrementally and traditionally, that's why we did what we did. But now we have materials such as bulk fills that literally help us. It's not necessarily the shortcut or cutting or corners, but what you're doing is literally you're taking a material that has the ability to be light cured. Depth of cure is not a question. These all are tried and true and proven now. And literally you can sometimes cap them. Others are more aesthetic, where you can take them straight up through the preparation. We'll talk about that in just a bit. So why do you want to do a bulk fill? Incremental placement is time consuming. And those 2 millimeters of literally every increment that we're placing do take time. Not only is that and the reason we're doing that is to help reduce the polymerization stressors that were placed in these different materials, because as they would shrink, and the composite and the resin materials would shrink, they draw in those surfaces. So then you have post-operative sensitivity, potential for fractures, various other just presentations and symptoms that lay out over time. So what we've come to know is that bulk fill materials really offer a material that can be placed incrementally in 4 to 5 millimeters in depth, and more importantly, successfully light cured. That's really a huge advantage. We've got great studies. All these materials work well. I think it's how you learn to work with them within your practice. I think it's the outcome of what feels best in your hands, what you learn to manage, what you learn to master. So here's the critical elements to consider if you're wanting to get into this market. Understand that each of these have a different depth of cure. Some are 4 now, some are 5 millimeters. Some require a capping or more aesthetic layer that needs to be placed. Irregardless, if you're going to do the capping layer, it has to be usually 2 millimeters just for strength, depth, and durability of that restoration. All of these materials work well. I've said that earlier. I'll say it again. It's just how you choose. What do you want with bonding? What's the easier bonding agent to use within your practice? What works best in your hands? What are your best outcomes and practices? Talk to your colleagues, read the studies, look at what the materials are. So bulk fills, what are you going to choose? Right now we have regular bulk fill and viscosities as well as flowable. Now, regular materials are going to have a higher filler content. They're going to be they're going to be thicker, obviously, more viscous. You're able to actually sculpt them, and they do not require a capping layer. Again, they have a lower wear, so that's a good thing. Now, traditional flowables in a bulk fill are going to have that lower filler content, so their material and mechanical properties are not going to be as robust as what a regular type viscosity bulk fill would be. They have more wear, obviously. Obviously, they're going to be more difficult to sculpt as well, and they do require a capping layer. But we can use these in combinations to create what we want to have, a final outcome that can be beautiful and durable and make that happen. So this course is really about clinical cases. So let's look at a class 1. Very simply, I'm going to use here a 330 pair. We want to make sure that we have rounded line angles and angulations on everything. A lot of times, if I need to smooth any kind of occlusal tables, I'll drop to my flat cylinder at 1710, a medium coarse diamond, and make sure that I can smooth out as much as possible and be conservative at the same time. And literally, I'm going to make sure that, again, rounded line angles are really critical. You're going to have your resins be able to flow and manage into those areas and spaces much easier and better. If I need to do any kind of decay removal, the beautiful thing about electrics, right? If you're using them, you can dial down. Here's a number 4 round burr that I'm using on a slower speed. I'm going to drop this down. I like to remove decay at around a 20,000 RPM issue of 1-to-1 on my electrics. And I use water on my slow speeds. It's interesting how, in dental school, we come out and we weren't using really any kind of water whatsoever on slow speeds. And when you start to move into the electric handpiece realm, you really can benefit from not only the water value and just really keeping that tooth moist and hydrated while you're working on it and restoring it. But you can also benefit from illumination too. So if you're not in that category of electric handpieces or you're considering it, I highly recommend that you go there, because your level of dentistry will just massively increase just because of the handpiece you're using, the tactility that it provides. That really creates a great, great outcome. So that's how I remove decay. And you can see here the undulated surface. One of the things that I start to think about when I remove an older amalgam and it has decay, I start to think about what material is going to best adapt to that undulated surface. And this is very irregular. Placing a traditional style composite in this prep is going to be questionable. Am I going to be able to get into all of those areas and do that successfully, not have any voids or any kind of even bubbles or any kind of issues where I just don't have that beautiful adaptation that I need. So I really need to think forward and going, I need a material that I can restore that really can beautifully adapt to all of that undulated surface. Because the presentation here has equal amounts of dentin and enamel, I'm going to use the selective etch methodology. I'm going to go ahead and etch the enamel and place it on the enamel for 15 seconds. And sometimes if you feel the necessary reason to go ahead and etch dentin, if you're going to do that, I recommend you go no more than 5 seconds. There's some great studies out now that show that. That way, again, you can reduce your post-operative sensitivity. In this case, I did predominantly just selective etch, as you can see in both of these teeth. At that point in time, I'm going to thoroughly rinse each of these teeth for 5 to 10 seconds. And I think that's so important. Again, keeping them hydrated. They're not going to be allowed to dry out. We want to make sure, again, we got to think about that pool noodle analogy, keeping that dentin moist. That's going to work the best and the easiest to accept that bonding agent. Next, I'll take my universal bonding agent, fresh drop, 2 brushes here, 1 per preparation, and I'm going to scrub and agitate all of those surfaces that I plan to restore. I'll drop that in initially into that dentin and literally work that around the axial walls, the occlusal table, the enamel surfaces, and really make sure that that's completely just saturated. And at that point in time, then I'm going to air thin each of these individually, clear that airline, make sure that you have nothing, just only pristine air coming out of that air water syringe and going across that surface. And literally at that point in time, you're ready then to light cure finally then. And at that point in time, I'm going to place my bulk fill. Now, here's where I know I can win with material choice because of that undulated surface that you saw earlier. I need a bulk fill material that is going to absolutely flow into these spaces and literally fill them properly and adapt. It's going to offer lower polymerization stress. It's going to have just that adaptation that is just what we need to make this restoration right and correct. Also, these materials now, many of these bulk fills, they have excellent radio opacity. Again, that's another consideration. If it doesn't, make sure you radiograph your material so that you know what you're looking at radiographically too. So just another tip. Now, when you're placing these bulk fills, many of these have to level and they have to level out themselves. I like the idea when I'm using SCR Flow Plus here. You can see here as I'm nozzling that, I literally just kind of take that to the base of the preparation, let that fill up and let that level on its own. I don't need to really tease it around. It likes to flow on its own. It also has a great self-leveling feature that I find to be very, very beneficial, even on maxillary teeth. And you'll see that in a bit too in another case, but this is an excellent material, tried and true. It has one of the lower polymerization stress values on the market as well. And I just know that in my hands, I like that little nozzle. It can get into smaller prep sites if we have those. We're able to access a lot of areas, class 2 boxes on the distals. Those are difficult and tough often. We need to make sure what we're placing is flowing where we want it to flow and go. Now, the key after you place this material and you remove your syringe tip is you want to let it level. It takes about 5 seconds for it to level. So leave it alone, let it level and do its job. That's what it will do. Now, then you're ready to light cure. And from that point in time after that, I'm going to place my capping layer. Again, this is a 4mm increment that I placed earlier with the STR Flow Plus. And then I'm going to take my TPH Spectra. And in this case, I like to use the light viscosity. It's a little bit easier and creamier to manage in place. I like to sculpt my restoration, so therefore it really reduces how much I have to finish at the next step. And I think this is a great tip and takeaway. If you can really sculpt as much as you can initially, then you don't have to worry about using your handpiece as much later on. And you don't want to have to interrupt that pristine surface or that bonded surface that you've just beautifully created. So it will really help expedite your finishing stage and literally help reduce your time factor too, if you can really sculpt this as much as possible. So that's a great takeaway and a little tip. Two of the tools that I use routinely, and these are all that I use to place every composite. I had both of these actually fabricated for myself, but you can go to companies and ask them to do this, but these work extremely well. I've got kind of a packable tip and I've got a sculpting tip. You can see here on the Friedman duck head and the Lattimore burnisher. And then I use the Nordent LRT curved with this flexible blade, and literally it is rounded enough that it can sculpt, and it goes wonderfully on flat surfaces, buccal lingual surfaces, and of course, marginal ridges. So here's that class 2 final after I polish that. When I'm doing polishing, again, I like to use a slow speed. I drop that speed down. I go down probably around 20,000 RPMs. I'd like to use water and just take a fine point. And I'm using, often I use enhance. The polishing points are just wonderful with this system. And you can literally, again, add a little water to that and lightly just touch that and really create that beautiful anatomy and the final result that you see. Now, challenges of class 2s. We all know that decay happens underneath the contact, and we've got to be cognizant that we've got to do a better job. Why does this happen? And, in this 2002 ADA study, already then they were finding that 37% of composite resin was insufficiently cured. So I attribute this to several factors. Obviously, you got to think about what are the components that you're using to framework this restoration with. And we know sectional matrix components now are really critical to create beautiful class 2s. You've got to have a pre-contoured band. You've got to use a proper wedge to seal that box. And of course, then you want to use a separating ring to help restore that contact that you need to reestablish. The other considerations you need to think about are the adaptation of that material, as well as the depth of cure. And I blame, honestly, many curing lights at that point in time maybe weren't as viable and reliable as they should have been, or perhaps our methodologies weren't as good as they could have been. So irregardless, whatever materials we're placing in those class 2 boxes, they've got to be cured to the depth of cure. And think about once the restoration is completed, you want to cure again from the buccal and lingual. So I think this will help establish a better pattern. So here's some of the light curing recommendations that are current right now. Regardless of the curing light, get a new curing light. Make sure it's LED. Make sure that you have the power output of 600 to 900 milliwatts. I know around 800 is really a good area to be within. The other thing you need to think about is when that beam exits the light, what is the diameter of that? And just because maybe the light head looks like it's large, maybe the beam is not quite that large or equal to that framework. So again, check your light, work with it, and understand it's got to stay focused on that area that you need to cure. You need to use a finger rest, eye protection, do it correctly, and don't shortcut, because you can see what happens. Now, with this class 2, you can see here radiographically, pretty straightforward class 2 on a premolar here. And I'm just going to walk you through the study, but what I've come to learn is, and this is a great study that was done in 1998 already, but it appears that conventional aproximal box preparations result in significant damage to adjacent tooth surfaces. So here's the takeaway. Before you even start to prep your class 2, I'm going to recommend that you protect the adjacent surface. And you do that with a neat little gadget called a wedge guard. Slide that in there. You want to make sure that the wedge is securely into that space, that interproximal space. The beautiful thing about this is, not only does it protect, and that little metal fin protect that adjacent surface, often you spend more time trying to make sure that's smooth, when in fact you could have just placed this wedge, peel off that little guard portion, and then continue forward with your restoration. So here you are already pre-wedging, ready to work at and reestablish that contact. So this is a great takeaway, and add into your armamentarium procedure if you're not doing it right now. Here's what that wedge guard looks like in place. Simple and easy. I always try to approach from the easiest surface and side. And you can see here the buccal or the facial surfaces is how we slide that in. And you can see exactly how that stays placed. This is nice in the factor that it has a little opening that we're able to grasp that with a pen pliers, a little pen grip pliers, that we can pin grip pliers, rather, I should say, and we can grab that and remove that and continue forward with our restoration. Next, you want to make sure that the sectional matrices that you're going to select is going to do two things. It needs to match the tooth size, and all of these come in different sizes. They have different coatings on them, but the takeaway here is make sure that the matrix actually matches the height of the marginal ridge of the adjacent tooth. That's very important. The other thing I want you to think about is, once you've placed this matrix band into the proximal surface, make sure that you keep it as smooth as possible. I personally do not like to burnish these. I like to take that flat curved tool, that LRT that I talked about earlier and showed you. And I like just to kind of fan out that matrix band against that interproximal adjacent surface. I think that maintains the integrity of these bands, because many of these bands now have beautiful anatomy. It's bi-directional anatomy that restores that contact. Some you can see here have a little gingival apron on them. Some are more subgingival built. Regardless, the height needs to match. Make sure that you fan that band against that adjacent to surface and maintain the smoothness, because then you're going to have a beautifully smooth interproximal restored contact. And here you can see that final result here, exactly the material I'm using, and rated graphically how well my materials adapted. Again, this was an STR Flow Plus along with TPH Spectra LB. Beautiful result. Let's talk about more difficult cases where you're sealing a box here. And you can see this is class 2 on this molar here, which is very challenging. One of the takeaways I've learned over time is floss the contact before you even start. Many of these teeth have a different kind of feel in the contact, and maybe they're a lighter contact before you even started. So understand what that contact feels like initially. Again, you can see I'm using the 330 carbide burr, and often on a larger preparation like this, I'll use 1156 straight dome, and I'll make sure that I smooth everything out. And again, it's rounded so that it lends itself for the proper resin preparation to be restored. You can see here now I'm able to place that matrix, and this is Paladin Plus system going into that area. And with the gingival band I'm using, it literally tucks underneath and really keeps that box isolated. And once I've placed that wedge in there and secured that and placed the band on that, it absolutely is tight and sealed and isolated. This is a case I would have loved to use a rubber dam on, but the patient it was in the spring season, and she had a lot of sinus issues. And I'm going to tell you, she was coughing, and we were able to make this happen as quickly as possible without a rubber dam, although I would have, like I said, used it. But I was able to rely on just good materials that worked efficiently. And you can see here how isolated that restoration was. Now, one of the things you need to understand, again, going back to thinking about a bulk fill, you need to measure. So take your perio probe and just place that into that gingival box to understand what is the height of perhaps 4 or maybe 5 millimeters that you want to place your initial bulk fill level. And in this case, that restoration, you're going to have probably around 8 millimeters. So there could be easily 2 incremental bulk fill layers that you would place. So you need to measure that and make sure that you're following all of those guidelines. So you want to measure and mark that depth. You want to keep the tip submerged, obviously, like we talked about earlier for the adaptation. Make sure that you're literally following the manufacturer's instructions for how long and depth of cure that you're going to use that curing light, and make sure you're curing each of those increments appropriately. So in this case, I'm going to do a selective etch methodology again, because I've got equal amounts of dentin and enamel. 15-second etch on the enamel. Carefully, thoroughly rinse that. Keep the tooth completely hydrated. At this point in time, often I get asked a question, do you apply a desensitizer? You can. I personally do not. Because I really rely on just my adhesive method to do this, and really have refined my technique with this. But this is a stage right there at that point where you could apply that. Now, here's my universal bonding agent. If you're using any of the chest pieces that, many of these bonding agents come in chest pieces, individual unit doses, make sure that you cap them. I use plumber's tape, very simple and easy to do. But here's my prime and bond elect. I'm going to, again, scrub that thoroughly for the 20 seconds, and then air thin that, and then properly cure that. Now, cavity preparations such as this, and it's a large, you want to make sure that you're taking your curing light and you're literally taking a uniform beam into that preparation. But then think about this. Think about any areas that could be shadowed. So once you've done a good 20 seconds, I would take another 5 to 10 seconds and just directionally rock that light back and forth and really create and make sure there's no types of shadowing whatsoever, because we know that shadowing, literally, if it's shadowed in certain areas, you're going to have a 40% reduction in bond strength. So it does affect your material. So you've got to properly cure them. You want to really minimize any kind of micro leakage that you can have. And light curing is essential to having a proper restoration. So here's that bulk fill placement again. You want to submerge that tip in the deepest portion of that gingival box. You're going to syringe it. The nice thing about this material, I don't have to tease it. I don't have to take an explorer or something that could perhaps contaminate that. You just place it in that box and let it fill and flow. And that's exactly what it does. You don't have to swirl it around. It will stay placed. So you can see here, I was able to put a 4 millimeter increment that was equal and level to the occlusal table. And at that point in time, again, allow for leveling. And in this case, it's 5 seconds. And then I can go ahead and light cure. And I'm going to use a light cure, and I'm going to cure this thoroughly for a good 30 seconds. Here's why. I think a longer value is better for this because it's a wider preparation. Deeper in depth, we get the 4 millimeters, but I just want to ensure a full and total cure. Again, I'm kind of really just rocking that light back and forth to that additional 10 seconds that I talked about. So the solid 20 seconds and then up to the 10 seconds where I'm back and forth. Now I'm going to place my composite capping layer on top of this. I'm going to go ahead after I've just literally placed this material, and you can see how I'm using my instruments to just kind of mash this in and start to sculpt my anatomy and really make this a beautiful restoration. Here's a takeaway that I've learned too over time. Some of the situations where we have marginal ridges that fracture, one of the ways to avoid that, and if you're having that happen, if you're really using square anatomy, the marginal ridge has to be rounded. And there's some great studies out that show by rounding the marginal ridges, you literally can avoid having the situation where you have more fractures. So if you're not rounding your marginal ridges right now, you need to do so because it will definitely reduce and any kind of fractures will lengthen the life of that class too. So how do you go about that? That's that curve tool I showed you earlier. So I'm literally going to take that on that marginal ridge and I'm going to fan that area and round that out. And that will help make sure and ensure there's a nice, robust material area there that's been filled in. After that point in time, I'm obviously going to light cure that. And then once I remove all of my band and my wedge and my matrix and everything, I'm going to light cure thoroughly again for another 20 seconds from both the buccal and the lingual aspects of that restoration. Finally, then I'll finish and polish. You can see here the tools that I'm using to do that. These are all standard tools that all of us have and use, but I really just try to minimize what I need to use because I want to master it and create a beautiful restoration. Again, those beautiful little enhanced polishers, these are the mini polishers. And if you use these, again, wonderfully, use them with a slow speed, dial it down and just use a little bit of water and just really kind of just light touches and just kind of touch those areas and really make that material just really pristine and beautiful. Now let's talk about a molar and premolar back to back because these get very difficult. They're quadrant dentistry at its finest and they're challenging. They're time consuming. They can literally take a full hour. So here's that pre-wedge we talked about, but more importantly, the wedge guard that goes in to protect that adjacent to surface. And I really think you'll save time. You'll find this it really expedites a better contact and a better procedural flow if you start off your class 2s with this type situation. Here you can see I've removed now that older amalgam. I'm starting to framework out and use the different matrices and the different rings. Again, all of these systems, they work well, but here's what I'm going to recommend. Work with these, different matrices, see which bands are more stable. And I know that's one of the reasons I kind of gravitate to the Paladin Plus system because their new ring is very stable and I find it grips in and it also is easier to clean. It has a new plastic coating on it that really repels a lot of this adhesive that when you're air thinning, they don't tend to get as mucked up as some of these others do. So if you haven't tried that yet, try that new ring system. I think you'll find it works well. So here we're going forward with this. I've done the selective etch. I'm applying my bonding agent. You can see we're air thinning and now we're getting ready to light cure. And you can see what the surfaces look like in both of these preparations. Now I'm going to place my bulk fill material again in the deepest portion. Allow for that adaptation and that leveling feature. You can see here, I've already completed the premolar and I'm focusing predominantly now on the molar and I'm going to go ahead and remove and just take this off and fill this up completely. Many times I get asked about warming composite. I do like warming composite. I think it helps to flow better. I think it helps to also lower polymerization stress. I think it's just a great adjunct. It's a simple process to do. We have to deliver composite anyway, so why not give it a little bit of warmth? I think that you can sculpt a little bit easier and better, and I just find it to be a simple thing to do, but has a great outcome. So here's my materials. I'm going to go ahead and finalize it. You can see I'm rounding in the middle picture here, that marginal ridge, again, to really to capture and recapture that strength that you need for that marginal ridge. And again, light curing all of this. I want to make sure too that I remove my rings so I successfully can light cure around those areas too to make sure that I've got a thorough cure and a depth of cure correctly. Here's the immediate removal of all of that armamentarium. And you can see now I'm going to take my finishing burrs and appropriately capture all of that final anatomy and just kind of enhance that a little bit. And then we're going to polish that again nicely, easily. And again, with a series of cusps or discs that you're going to use, you can gain a final result like you see here. So seems simple, seems easy, but it's not. It's all step by step, but good choices. Let's talk a little bit about minimally invasive preparations, because this is a hot topic now, and I know it's really critical that we treat these appropriately, but I like to use a pointed cone. It's like a 1300 FS. I like this. It's very small. It's a pediatric style type of burr, but I like it. It has a very small diameter tip, and you're able to access easily into a lot of these and really these carious lesions and really restore them correctly. But here's the takeaway. Now we know with different flowables, we have these different delivery systems, different syringes that we're able to get into these preparations, because a typical composite compule is very difficult. You've got anywhere between 2, sometimes these even have maybe 3 millimeters of delivery on that cap and tip that you're going to place that resin in, and it's really hard to adapt. So it's nice now that we have materials that are far more enhanced than ever that literally help us deliver into a very narrow area to create a great result. And some of these highly filled flowables are a great choice for this. They are improved in strength. The tip diameter is small, so you have easy access into preparations like you see here is these class 1s. Even in some of the class 2 boxes, they're difficult sometimes to access. These make it so much easier. These are all radio opaque. They all work very well and have great universal applications. So if you're not into this market yet, I'd highly recommend you go there. Here's Janelle Universal Flow. This is a terrific product from GC America. Absolutely love the final result on this. I love this material. I think it flows well. And for this indication, it's my choice, hands down. For class 5, and many of these have, these are very standard now than ever. We see these routinely, right? My methodology in doing this, I'm going to place a long bevel. I'm going to go 3 millimeters into that enamel to really make sure that I've got a nice long bevel that I can gain, again, an adhesive advantage by doing a selective etch method. I'm going to go ahead and do that for 15 seconds, rinse again, keep moist. Now I'm going to apply my bonding agent. I want to get that semi-gloss appearance. And I'm really going to scrub that very effectively, thoroughly into that area, and then go ahead and air thin that and light cure it. Then you're going to see a beautiful combination here now of SDR flow. Again, you can use any kind of flowable that you think is highly filled as well. Many of these have offered flexural strengths that are greatly improved. So there's some good choices here too. So again, light cure that as well, then place your composite capping layer. That's very aesthetic. And I think you come away with a very, very beautiful restoration that is just absolutely stunning. It's smooth to the tongue and beautiful, and you can see the result here. And it's long lasting too. So great service for patients as well here. A few more strategies here. Many times we have, presentations that come in with over contours of those interproximal surfaces. I like to take not a finishing burr on a high speed, but rather I like to use a Soflex disc. One, because it's curved and I can literally go in and round that area, which is a bidirectional contact, and recontour that. So once I've got my tooth prepared, and you can see here, we're just starting to get into this area, I really realize I've got to do something to that adjacent surface. So I'm going to go ahead and use a Soflex disc or any kind of disc that you have, and really just go in there and take that premolar on the distal, that aspect, and really contour that to get a better contact established, because you will not get a good contact with what you see here. So that's a takeaway. On adjacent restorations, really important to understand, once you place both of those bands, I'm going to go ahead and place my A composite initially, remove that band. I've got my wedge in there already. Then I'm going to go ahead and create like literally a class 1 restoration, because I filled up that box. Now I'm going to fill in the B portion. And then literally now I can take these and I literally have what you see next door here. I've got 2 class 1s now. So fill the distal tooth first, initially fill that mesial portion, then remove the band, keep the front or the distal of the premolar, the first premolar there, keep that distal band in place, build that distal contact. And again, you can light cure into these, make sure you have a thorough cure, a thorough depth of cure. And I think this makes an easier restoration to finish out than as just an occlusal. So that's exactly my methodology on many of these, and I do now. And then you can fill these back together and back to back, and they're all done. And you have a beautiful result that looks just like that. So I try to simplify that. Pulpal protection is a really big challenge too. What I believe in, whatever material that you place, it needs to be a liner that's placed correctly, appropriately. Often at this point in time, once we prep the tooth, I'll go ahead and I'll take a 2% chlorhexidine and I'll literally blot that into that area to create kind of a bactericidal event there. And then literally the tooth again is moist, and I'll place my pulpal protection. All of these materials work well. The Theracal, the Vitribond, and the Fuji line, they all work extremely well. Again, I think it's important to have protection for the pulp and have that again in your toolkit to go to as necessary. For buildups, one of the things I've taken away too is anytime you have a wide or a contact area that really is no contact area, as you can see here in this case, an example, or you have teeth that are rotated. Again, great example of all of these. You've got to have a strategy, because placing just a band in there, you're going to have a difficult time with a ring to hold that area to separate that correctly, because you don't have a contact even to start with. So one of my go-tos now that I found very highly successful is a Paladin 360 band. Now, what I've come to learn is matrix bands like Toffelmeyer's, they will twist on that tooth, and they're clunky, and they're just really, they just kind of get in the way of the procedure. And especially too, like if you're light curing, even flat bands, they just don't provide the contour. So the Paladin 360 band, circumferential band, I found has been a great winner. Literally it sits individually on that tooth. You can finger tighten that. You can see the contour that's providing. It has an anatomical contour. It's not flat, it's anatomical. And you can see the final result here on the finished case here, and how beautifully that was able to be restored. And I think, these approaches, and these are great little extra tidbits and pearls that you take away that make your job a little bit easier when you have those types of big cases. I want to thank you for your time, and I hope you have a great rest of the day. And I know probably many of you might have some questions, so we'll start to entertain those as we go forward.
Thank you so much, Dr. Trost, for sharing your knowledge and insights on posterior composites. And of course, thank you to Dentsply Sirona for sponsoring tonight's webinar. Everyone in attendance tonight will receive the recording via email sometime in the next week. And lastly, if anyone is interested in attending future Henry Schein webinars, visit henryscheindental.com/webinars for our upcoming schedule. Thanks everyone for attending. Have a great night.